Hello. Yep, I think students are there here. Hello. Anyone? Hi. Good evening. So I think you'll be knowing the topic for today. We are going to discuss on the lithium poisoning. So we know where lithium is used and what are the mechanism of actions. I think you all will be clear. And thank you, Srikanth. Thank you. I'm fine. And hi, Sagarika. Hi, Balasubramanian. So a big hi to everyone. So today, as I told you, we're going to discuss with the lithium toxicity because I am doing some toxicology sessions continuously for some time being, because toxicology is something which is not very clearly understood by many students. So they requested for toxicology, so I think anyway I'm doing a free session in the YouTube, so I wanted to finish off certain toxicology session. So today is a very important topic on lithium toxicity. So we know how lithium acts and what lithium is, and what is the importance of lithium in medical practice, and what is the importance of lithium in our routine chemistry. So lithium, it's in the group 1 of the periodic table. It comes along with sodium and potassium, and you have lithium and other elements are there in the group 1. So but the most abundant elements in our body are sodium and potassium only. So that is where the problem is, because it's a group 1 element, and already sodium and potassium are very abundant in our body, and we are very accustomed to use sodium and potassium in our body for many physiological reasons. When you give excess of lithium, they are going to replace the sodium and potassium, and they're going to produce some complicated effects in the body. So that is the problem what we are going to face with lithium toxicity. So what is the usage of lithium? I'm not talking about the mechanism of action of lithium. So if you know the pharmacology, then that's fine. So if you want, I can explain, but that's a very simple thing, understanding a lithium pharmacology. But anyways, so lithium is used to treat the bipolar disorders. So we are going to treat with bipolar disorder. So that is the usage of lithium, and many patients we see, because these patients' mood is going to fluctuate. So they're not going to have a very constant and consistent mood. So if you take this is the euthymic zone, which means the mood is stable. Below that we call it as depression, and above that we call it as mania. And we have two types of mania, right? So we have hypomania and we have a mania. So both have their individual definitions, which we're not going to discuss in this video because I just want to outline. So let us assume this is the hypomania, and this is going to be the mania. So mania is a little different from hypomania. It's a more severe form of mania, is what we call as a true mania, and a little bit lesser severe form is what we refer to as a hypomania. So this bipolar disorder patients often generally tend to have two types of BPD. One is BPD type 1 and BPD type 2. So you might encounter patients like this, so who will be having cycling like this. So they may go for mania, and once again they go for a depressive disorder. So this is a bipolar disorder type 1. Where they're going to cycle between mania and depression, and they may have some normal mood in between, doesn't matter, but they generally tend to cycle like this. So suppose if the patient is having a bipolar disorder type 2, so they tend to cycle with hypomania and a depressive disorder. So this is what we refer to as a BPD type 2 or a bipolar disorder type 2. So they don't have a full-blown mania, but they tend to have a hypomania, and they tend to alternate between hypomania and a major depressive disorder. Apart from that, they may have a full-blown depressive disorder only, so which means they will not have a manic attack at all. Only thing they will have is at least one or more depressive episodes in their life. So that is what we refer to as a major depressive disorder, or as MDD. So where they do not have any manic attacks at all, but they only have a depressive episode. But we are very clear about certain things, that lithium is not that beneficial in major depressive disorder. Lithium is effective only in the mania, especially during the manic attacks. Lithium is very helpful compared to the bipolar disorders as such. Lithium is most effective in controlling the mania, and often lithium is supposed to be a mood stabilizer rather than telling it as it's going to be helpful in treating the mania, but more than that, it's going to be a mood stabilizer. That's what lithium is all about. So we have discussed about the basics. You have BPD1, BPD2, and the major depressive disorder, and lithium is going to act as a mood disorder, mood stabilizer, rather than it's going to act on the particular area. So apart from that, why this patient should develop lithium toxicity? Because we know that bipolar disorder patients are going to alternate between your mania and depression. So that is where your lithium comes into it, because once during the mania, usually they don't have that much of suicidal ideation, but once they go for this depressive episode, that is the time we have to be very careful, and that is the time they are likely to ingest. 1 second, so I think somebody is telling voice lag. So voice is better now, so is it still lagging? Is it all right? Is it all right now? Yeah, thank you. So that's how lithium is a problem. So especially during the depressive episode, so that's where you're going to get an issue. So, and we know what is the problem with lithium. Lithium is, it has a monovalent cation, so that's 1 plus. So it's in the same periodic table as that of sodium and potassium, and that's where the problem is. So lithium can replace both these ions, and sodium is going to be in the ECF, and lithium is going to be in the ICF. We know that, but it's going to produce complicated effects, especially when these ions are replaced in the body. So it's going to result in extremely complicated effects. And at the same time, we know what is the lithium's mechanism of action, and that is a basic pharmacological mechanism of action. But this replacement of sodium and potassium happens at toxic doses, and that is a toxic mechanism of action. But pharmacological mechanism of action, we know we have something called IMP phosphatase. So that's what lithium is going to inhibit, thereby preventing the recycling of IMP into your IP3. So that's where lithium is important. So that's how its pharmacological effects are mediated. And at the same time, it is going to inhibit a very important kinase called GSK3. And GSK3 is very important for the beta-catenin pathway. So this is the pharmacological mechanism of action. So that's how lithium works basically. But apart from that, toxicologic principle is something different. It's going to work by replacing the sodium and potassium ion. So that's how lithium is going to produce toxicity. And what are the kinetics? So we have to know the toxic kinetics with regards to lithium poisoning. So what are the toxic kinetics that you're going to encounter? So first, what is absorption of lithium? So absorption of lithium is complete by 6 hours. 6 hours it is almost complete, the absorption, and the peak concentration will be reached at around 4 hours. These principles are really important to an extent, because this is what is going to detect, this is what is going to tell you what is the level of treatment that you're going to give in this guy. So that's why these are a little important, relatively important. So just pay attention for some time, even though it's a number-based things and a little vague, but still it's better just pay attention a little bit. And at the same time, so especially if the patient is taking overdose, the kinetics may be a little different. The patient is taking overdose of this thing, so altered kinetics will be there. In this condition, the peak concentration may be delayed by 12 hours, so can happen at 12 hours. So this is a normal kinetics we have discussed, but in the overdose situations, the peak kinetics, the peak lithium levels can reach up to 12 hours. And at the same time, we are going to use slow release preparations. So in those settings also, your kinetics may be completely different, because giving slow release preparations are very common in psychiatry practice, and at the same time, currently this is the norm, because to avoid certain complications we tend to give a slow release preparation, which are little costly but still it's beneficial for the patient. But if they are going to take slow release preparations, it's going to be a little bit altered kinetics. I'm writing a bigger only, okay fine, so I'll try to make a little bit bigger. So it's going to produce more altered kinetics, so which you have to take into mind. So similarly, the excretion is going to be in the urine, so through the kidneys. The excretion is going to be in the urine through the kidneys. So remember, this excretion is completely dependent on the GFR. So that's what a very important point to understand as well. So this is going to be completely dependent on the GFR. So in a patient who's having a renal disease, lithium toxicity is even more likely. So you have to be very careful about that. So lithium itself can cause renal damage. So what are the renal effects of lithium? The same thing they are going to do in the kidney as well. So that happens in chronic ingestion. Chronic ingestion, we know there is a distal convoluted tubule and the distal part of the nephron, that is a collecting duct. In that you are going to have something called a P cell. In the P cell we have certain important channels called as epithelial sodium channels, which are going to respond to aldosterone. So these are aldosterone sensitive sodium channels, and obviously we know sodium is going to move in. So but as I told you, sodium can be easily replaced by lithium. So in this setting, your lithium can enter through the distal part of the nephron through the epithelial sodium channels, where it causes the same cellular alterations by inhibiting the GSK pathway and disrupting the inositol triphosphate pathway through the that's the GQ pathway, and that's going to be disrupted as well. So once it's going to disrupt, you are going to result in damage to the P cell and the nephrons in the distal part of the area. So once these nephrons are damaged, you're going to result in poor absorption of water, and it can result in a condition called nephrogenic diabetes insipidus, where water cannot be reabsorbed in response to ADH, and there will be so much of free water that will be extracted in the urine. So in this condition, you will be resulting in a condition called nephrogenic diabetes insipidus. So one of the important causes of nephrogenic diabetes insipidus is chronic lithium ingestion, or lithium toxicity. In chronically it will cause nephrogenic, but acute toxicity will not result in nephrogenic diabetes insipidus. The chronic toxicity and chronic lithium intake can result in this complication called nephrogenic diabetes insipidus. So that's where the problem is. So that is also the reason why we use a drug called amiloride. So especially when you are suspecting a chronic lithium toxicity, or you want to prevent a chronic lithium toxicity, you can use amiloride, which actually blocks the epithelial sodium channel. So once they block the epithelial sodium channels, you prevent the lithium from moving inside the distal part of the nephron and exhibiting some toxic effects. So that is why amiloride is actually beneficial in the setting of nephrogenic diabetes insipidus, but only due to lithium. So if it is not due to lithium, then amiloride will not be helpful, but it will be helpful especially when you are giving in the setting of chronic lithium ingestion. So that's how it's going to work. So we have to treat a patient with lithium toxicity. So how we are going to treat a patient with lithium toxicity, that's the question is. So obviously first, as I told you, what will be the picture, because picture is going to be a little bit different between acute ingestion versus a toxic ingestion. So let us see what will be the effects of acute toxicity of lithium and what will be the effects of chronic toxicity of lithium. So both are a little different. So acute toxicity, the toxic dose we have to know. So what is going to be the toxic dose in acute situations? Not amlodipine. We are talking about amiloride. So amiloride is different. Amiloride is an ENaC blocker. So I didn't tell amlodipine. It is, I don't know, amiloride. So that's an epithelial sodium channel blocker. It's a potassium sparing diuretic. So toxic dose of lithium is approximately around 25 grams. So anything more than 25 grams is going to result in acute toxicity. Chronic, we don't have any data because the patient will be taking for years together. So you cannot find the exact toxic dose. But even though taking for years, at least more than 12 to 24 months will increase the chronic toxicity. That's why lithium is not given for a very long duration by many psychiatrists right now. And at the same time, the toxic level in acute ingestion, we don't know because the pharmacokinetics is very different, especially when they take, depending on the different type of formulations. But in chronic dose, if it is more than 2.5 millimoles per liter, it's going to be toxic in this situation. So peak concentration of lithium, usually in acute ingestions, it happens around 4 to 8 hours, as I told you before. and it might take more than 2 hours if the patient is taking a slow release preparation or a very massive ingestion. So massive ingestion or slow release preparations, it can take more than 12 hours, as we discussed already, but there is no peak concentration here. We want to know only the toxic level in this situation. And at the same time, the body compartment that is affected, this is the most important, because that will tell you what are the symptoms of lithium poisoning, whether it's acute or chronic. So what is the body composition? So body compartment that is affected. So usually the GIT and the intravascular compartment is the only thing that is affected with acute ingestion, because which means in acute ingestions you are going to get predominantly the gastrointestinal complications only. You're not going to result in CNS complications. That's a very important thing. But in chronic ingestions, the most important organ that is going to be affected is the central nervous system. So this idea is very important, because you need to start identifying the symptoms of the patient, at the same time whether to reassure them or not, how to resuscitate. All these things is based on what body compartment is actually affected. So in acute ingestions, only the GIT and intravascular compartment, and chronic ingestion is going to be the CNS that is going to be predominantly affected. So based on that, you can tell the clinical features as well. So what are the clinical features? If they are going to take small doses, they are often asymptomatic. You don't have any problem at all with small doses at all. So you can just reassure the patient, observe the patient in the emergency room for some time, and you can dispose them off. This is quite common in our practice, where the patient during the depressive episode, or even sometimes during the manic episode, they tend to take very small amount of tablets, like maybe because we give lithium in 300 or 600 milligram formulations generally. So they can take like 10 tablets or 15 tablets, and that's okay. So that will not cause any big impact. So that's not an issue. This is the commonest form of toxicity that we'll encounter in emergency practice. But in little higher doses, the most important organ system or important compartment that's going to be affected is the GIT, where they're going to typically cause nausea and vomiting, abdominal pain, and diarrhea. So the classic problems of GIT, where you're going to write in your second year as side effects for every single drug. So nausea, vomiting, abdominal pain, and diarrhea. And apart from that, neurotoxicity is very limited. It can cause neurotoxicity, but during the acute ingestions, it's very limited. So neurotoxicity will not happen. If it is an adequate GFR, the condition is there. If the patient is having adequate glomerular filtration rate, which means if the kidneys are doing their function very properly and the kidneys are excreting the lithium properly, then in that setting, your neurotoxicity will be very limited. So maximum what you'll be getting is the tremors. That's all. Maximum you'll be getting tremors. Apart from that, you won't get any element of neurotoxicity in with respect to acute lithium ingestions. I don't know whether it is hanging or not. So I'm doing the same thing. I'm not doing anything. It's the OBS software I'm using. Like what? I don't know. Maybe the network is a little poor. Let me check on that. Now it's fine. Okay. Dr. Preeti is asking fine or coarse tremors. Usually acute toxicity will result in fine tremors only, and chronic toxicity will result in coarse tremors. So that's how we have been taught. Okay, thank you. So the clinical features of chronic toxicity is actually, we have classification as mild, moderate, and severe. Yeah, so mild, moderate, and severe. So that's what you're going to see. So this is given by Hansen and Amundsen, that is called as Hansen and Amundsen classification. So mild as well as mild, moderate, and severe. So what about that? So mild features will be tremors, hyperreflexia. Remember, in chronic toxicity, the CNS is going to be one of the major compartments that will be affected with lithium toxicity. So you will be resulting more of CNS issues, where you're going to get tremors, hyperreflexia. Patient will be a little agitated. Sometimes you might confuse it as mania, and I've seen certain I mean, it's not decision by emergency, but I've seen some of my residents taking it as a evidence of mania, and they're giving or increasing the lithium doses. So that is to be strictly avoided. It's always better to treat as lithium toxicity when the patient is coming agitated to the emergency, and they can get muscle weakness, and they can get ataxia. So this is going to be the features of mild toxicity. Apart from that, we are going to have some evidence of moderate toxicity as well, in the form of the patient may go for altered sensorium like stupor. They can go for complete rigidity. They can go for hypotonia and hypotension. So severe toxicity usually will result in coma. Obviously, we know that, and they'll be coming with seizures, and they'll be coming with myoclonus. So when they come with, I mean, obviously myoclonus is a sign of a injury to the brain. So that's all. So if you're going to have, so I think it's getting free up. So I did the RAM swap also. So I'm just freeing up the memory so that you will be able to see the things better. Anyways, mild tremors, hyperreflexia, agitation, muscle weakness and ataxia, moderate stupor, rigidity, hypotonia and hypotension, severe coma, seizures and myoclonus. So that's how it's going to be. So these are the clinical features, classification by Hansen. Apart from the treatment, so what are you going to do as a treatment in acute injections? During acute injections, you are going to use forced diuresis as a treatment. Whereas in chronic, you are going to use hemodialysis, especially if the serum levels are more than 2.5. So if the serum levels are more than 2.5, I'm going to take the patient for hemodialysis. So acute, just the forced dialysis is more than enough. So disposition, finally. So patients, if the patient becomes asymptomatic and serum lithium levels are less than 2.5, so then in this setting I can discharge the patient. So there's no need to keep the patient anymore in emergency room. There's no problem from here on. Suppose the patient is having chronic toxicity, there is no role for discharging the patient out. All the patients with chronic toxicity has to be admitted, and at the same time it will take usually very long time for the neurotoxicity to resolve. It's not like it will take a very short time. So you're going to have a very tough time here. So it's going to take a very, very long time for the neurotoxicity to resolve. Occasionally it may be very incomplete recovery also. So chronic toxicities are more dangerous than acute toxicity. And one more important problem that are going to face with chronic toxicities, the patient may be having associated nephrogenic diabetes insipidus. That is a very important thing. It's a very important side effect of lithium toxicity. At the same time, chronic injections may result in a setting of a distal renal tubular acidosis also. And rare scenario, but still it can happen, because distal renal tubular acidosis and nephrogenic diabetes insipidus are in a way related to each other. And at the same time, chronic injections may be associated with tubulointerstitial nephritis. So we have seen this as well in a patient who came with severe hypokalemia, tubulointerstitial nephritis. So we have seen that as well. So I mean, proposed mechanism, this was one of the few cases that have been described in the world, and we have put a paper on BMJ case report some maybe 1.5 years back. So what we found out is the mechanism is probably this. So what happens is, I told you lithium tries to go inside in the like place of sodium. So as lithium moves inside, we know that what is the mechanism. As lithium is going to move inside the cell in the setting of replacing sodium, so obviously you are going to increase the potassium efflux as well. So the urinary potassium loss is going to be substantial. So this could be one of the reasons why we had a patient who had a severe hypokalemia, chronic lithium ingestion, and who was taking lithium unregulated for years together without any prescription. So in that setting, you might result in hypokalemia. So what we found out is, in that setting, it could cause a tubular interstitial nephritis. One explanation for that is it can produce more entry followed by coupled with more exit of potassium, resulting in increased urinary potassium. So resulting in potassium wasting in the urine and hypokalemia. That's one explanation for that. Apart from that, it can cause direct damage to the nephron. So if it causes direct damage to the nephron, the potassium, sodium, all these things cannot be absorbed, and that can also result in potassium wasting in this setting. So it could be multiple reasons why certain lithium patients are taking very long time was having hypokalemia. So that's another important point to understand. So how we are going to treat these patients? So how we are going to treat? So we are going to use in the form of RSSI dead. So that's what we're going to use our treatment. We know that. So traditionally we are using the same RSSI dead. So R stands for resuscitation, R stands for risk assessment, S stands for supportive care, I stands for your ingestions, and D stands for decontamination, E stands for elimination, A stands for antidote, and finally D stands for disposal. So that's what we're going to use. The same principle we're going to see. First R in the ER is going to be resuscitation, of course, without a doubt. So how we are going to do resuscitation for these guys? So many of the patients with acute toxicity may come with hypotension, or even chronic toxicity may come with hypotension. Suppose in case if the patient is coming with hypotension, obviously you are going to do the standard fluid resuscitation. Everyone will be knowing what is the dose of normal saline that has to be given in standard resuscitation. So you are going to give IV 0.9% sodium chloride as 10 to 20 ml per kilogram bolus. So that's what we're going to give. So there are two indications for that. One, either if the patient is hypertensive or even if the patient is having severe GI symptoms, are considered to be dehydrated, because severe GI symptoms include vomiting and diarrhea. So they're considered to be dehydrated. In those settings, you can give a standard resuscitation bolus of 10 to 20 ml per kilogram. It's the standard for adults, basically. And apart from that, if the patient is having coma and seizures, this is a sign of always chronic toxicity. This will never happen in acute toxicity, as I told you. It's always a sign of chronic toxicity. In this setting, you have to think about stabilizing the patient as by treating with benzodiazepines. Same status epilepticus protocol, you have to start with benzodiazepines and you have to go accordingly. Remember, in acute toxicity, it's extremely rare. So then next R stands for the risk assessment. We know that. Already in the risk assessment, I have mentioned about the differences between acute injections versus chronic injections in detail already. So no need to go to the risk injections once again. Then S stands for supportive care. So what are the supportive care that you're going to give? Sir, if we give lithium for treating mania, at what intervals we should check serum lithium levels? I'll come back to that. That is something different. We are not dealing with the toxicology right now. That will be taking the topic completely in a different way. So supportive care, suppose if it's an acute overdose, you have to monitor the urine output in the form of continuous urine output, because you have to flush this lithium out of the system through urinary route only. So you have to maintain the urine output at more than 1 ml per kilogram per hour. So because low GFR and low urine output is associated with increased toxicity. So you have to make sure that the urine output is adequate, like more than 1 ml per kilogram per hour. And at the same time, you have to avoid all the nephrotoxic drugs, and you have to prevent certain drugs that impair the renal function, like ACE inhibitors, or the patient might be taking additional ACE inhibitors. So in that setting, you have to, avoid those drugs. And then decontamination and investigations. We forgot the S, I. So I stands for investigations. What are the investigations you're going to take with respect to lithium toxicity? So first, I'm going to take an ECG. That's the most important. And next, I have to take the paracetamol levels. So you might ask why I have to take the serum blood paracetamol levels in this setting. Because I told you already, the last toxicology session, if you remember, so we have 4 stages of paracetamol toxicity. In the acute stage, in the first stage, when the patient has just ingested paracetamol, they come only with GI symptoms, or they'll be completely asymptomatic, but they can come only with GI symptoms. There is absolutely no problem at all. And whenever a patient takes one tablet, it's not sure that you must have taken only one tablet. You'd have taken other associated tablets, and one of the commonly available tablets over the counter is paracetamol, Dolo 650. And absolutely, whenever the patient comes with lithium toxicity, especially if they have GI symptoms, then definitely I'll be liking to do a paracetamol levels also, because I don't want to miss that golden period for giving N-acetylcysteine. So in that case, I'll be checking the paracetamol. If the paracetamol levels are above the nomogrammic cutoff, then I'll be starting with N-acetylcysteine as well. So be very sure about it. This is a very practical point I used to tell my residents in ER. So always we check the paracetamol levels in any toxic injection that come with GIT symptoms. That's a standard one. And what are the specific investigations that you can do? Specific investigations, you can go for the ECG we told already. And what will be the findings in the ECG? So you'll be seeing very non-specific STT changes. So you won't get any problems at all. So you cannot take this as a sign of ischemia. That's quite common. And you can check for thyroid function as well. If the patient is taking for chronically, then you can check for thyroid function, because lithium is one disorder that can cause hypothyroidism. It can cause hyperthyroidism also rarely, but by causing thyroiditis. But hypothyroidism is very common with lithium because it interferes with the thyroid hormone release. So that's why previously in thyroid storm, once upon a time in thyrotoxicosis, lithium was used because it is supposed to block the thyroid hormone release into the bloodstream. So it can cause hypothyroidism. Previously it was used as a drug for thyroid storm and hyperthyroid cases, but currently we don't do that. So we don't use lithium for that purpose. But anyways, chronic lithium injections even now can result in hypothyroidism, and be a little careful about that. So you have to evaluate for the thyroid function as well. And D stands for decontamination. So you're going to do decontamination in this regards. I don't know why is this happening. Decontamination. So decontamination in this setting, you cannot do anything. That's a pretty important point because this is sometimes asked in MCQs as well. So charcoal is not effective. Acute charcoal is not effective in decontaminating lithium. So that is the point you have to note here, because it's been routine that they will give active charcoal. But if you think about a multiple injection, like along with paracetamol, then you can give a charcoal, not a problem. But pure lithium injections, or if you want to know that lithium will be counteracted by charcoal or not, there is no point. So lithium does not bind with charcoal, and there is no point in giving charcoal in a pure lithium poisoning. But if in case of a multiple tablet poisoning, you can go ahead with the charcoal, active charcoal. And you can do E stands for enhanced elimination, you know that. So how can you eliminate? So lithium can be easily eliminated by extracorporeal removal. So we know what is extracorporeal removal in the form of hemodialysis. So that's what we're going to do, HD, hemodialysis. And this is usually established in patients with renal impairment. So in acute toxicity, you need not generally do hemodialysis, because in acute toxicity, serum lithium levels can be extremely high. That does not become an indication for dialysis, because students think that if the lithium levels are more than 2.5, straight away they have to take for dialysis. But please remember the fact that in acute toxicity, the serum lithium can be as high as 5 or 10 millimoles per liter. So that is not a sign of dialysis. That is not an indication for doing a dialysis, because I told you in acute toxicity, it's going to stay within the intravascular compartment. So obviously your levels are going to be high in acute toxicity. So that level of more than 2.5 is definitely not an indication for doing a dialysis in acute toxicity. You just have to deal with your routine management, like forced dialysis. And in chronic toxicity, your levels are very important, where levels more than 2.5 definitely is an indication for dialysis. But acute toxicity, seeing a level as high as 5 or 10 millimoles per liter is not a surprise, because lithium is going to stay only in the GIT and the intravascular compartment. So definitely will be having high levels. Whereas chronic toxicity, intravascular levels will not be that great, because lithium tries to redistribute with the central nervous system. Lithium tries to redistribute among the central nervous system, which means if you see high levels in the intravascular compartment, which means the CNS is already saturated. That's why it's not able to go into the CNS and stay within the intravascular compartment. That is the reason why it's a little important to understand this mechanism. So HD, hemodialysis. In acute toxicity, hemodialysis is reserved only for patients with impaired function, impaired renal function. So obviously, when will you give hemodialysis? So hemodialysis is indicated in toxicity, especially if the patient is having impaired renal function, point number 1. And apart from that, if the patient is having significant neurotoxicity, so these are the indications for doing dialysis in the setting of a acute injection. Whereas in chronic injections, hemodialysis can be done if the serum lithium levels are more than 2.5. So this is for chronic injections. Obviously, chronic toxicity will come with neurotoxicity for sure. So that itself becomes an indication for doing a hemodialysis. So absolutely, there is no doubt about that. Most of the time, serum lithium levels in our center will take a long time to come. Like for example, they have to outsource it, and it's being a very uncommon drug in toxicologic scenarios. So it's not that easy to get chronic lithium toxicity. So in our ER, I have given a rule, like any patient, they come with neurotoxicity and lithium injection, even without waiting for the serum lithium levels, you can take the patient for hemodialysis, no problem. So this becomes the most important indication rather than the serum lithium levels. To be honest, this is what practically we do, rather than checking the serum lithium levels frequently and taking the patient for dialysis. So only two indications: one, either impaired renal function, or if the patient is having or exhibiting significant amount of neurotoxicity in that regards. And do they have any antidote for that? So do they have any antidote for lithium? No, there's no antidote. So this is something I want to tell you, because students think that, as I told you before, amiloride is considered to be an antidote. That's what many students do think. Remember, we are talking about an effective antidote here. We're talking about effective antidote here. So amiloride is not an antidote. That's a very important point to understand. Amiloride, then what amiloride does? Amiloride reduces the toxicity of lithium. It reduces the toxicity, but it cannot antagonize the lithium action. It cannot, reduce the toxicity in the sense only the nephrologic toxicity. Only the nephrotoxicity can be reduced. That's what amiloride does, but it cannot prevent the neurotoxicity. It only prevents the nephrotoxicity, that's all. So it cannot be considered as an antidote to lithium intoxication. It only reduces the nephrotoxicity. But at the same time, there is one small important caveat that you have to understand is the fact. And whenever you give amiloride to reduce the nephrotoxicity of lithium, there is a possibility with amiloride there can be increased levels of lithium. Amiloride can result in increased levels of lithium as well, because kidneys are some of the major organs that absorb the lithium actually from the blood by this principle. So if they cannot absorb enough lithium, the kidneys do not absorb. After giving amiloride, the blood levels of lithium can be increased. So that is the reason why in toxic conditions, in toxic states, do not use amiloride. In the sense, like when the patient is having toxicity, amiloride is not indicated. Why? Because already your serum lithium levels is high, and if the patient is taking, and if you give amiloride, it's going to further increase the levels of lithium. And if you further increase the levels of lithium, the toxicity will increase. So that is the reason it's not fair to give amiloride in the setting of acute or chronic toxicity. So where will you give amiloride? Amiloride is given only in the setting of nephrogenic diabetes insipidus. That's all. That's why I was very clear in the beginning about where to give amiloride. You're going to give amiloride only in the setting of nephrogenic diabetes insipidus. I don't know where I told you before, but I was very clear in that perspective. Yeah, so I was clearly telling it, you have to give amiloride only in the setting of a nephrogenic diabetes insipidus. Apart from that, there is no indication for giving amiloride in times of toxicity, but you have to be very, very, very clear about that. So there is absolutely no indication for giving amiloride in that setting. So because this is some commonly mistaken thing by the student, because they think, especially when they come to the emergency for the first time, residents, they think that like lithium has to be counteracted with amiloride. Don't do that. And final D, disposition. So disposition, acute injection. So disposition in the sense, what will you do in acute injection? As I told you before, if there is no evidence of neurotoxicity, plus once serum lithium levels are less than 2.5. Please understand the fact, if the renal function is good, and if you are giving a good amount of fluids and forced diuresis, in this setting, the serum lithium level should fall by 12 to 24 hours. Within 12 to 24 hours, even if the initial value is 5 or 10, the serum lithium value should fall within the next 12 to 24 hours. So once the serum lithium levels are less than 24 hours and the patient has no evidence of any neurotoxicity, you can discharge them, even from the emergency room itself. There's no point in admitting the patient. Suppose if the patient is having persistent elevation of serum lithium levels, or the patient is having some evidence of neurotoxicity like tremors, it's better to admit the patient. Don't discharge them. So there might be having acute on chronic injection also. You have to be careful in that setting. So chronic, as I told you, always admission. All patients are admitted, because almost every single patient chronic toxicity will have neurological toxicity. So you have to admit, and remember, chronic toxicity may take weeks to resolve. So that's what you have to get that. So the patient may be having a tough time in the hospital. It might take a lot of weeks to resolve. So usually in our setting, we calculate that average of it takes 2.3 weeks, around 2.5 weeks to resolve the chronic toxicity, the serum lithium level to come. But with dialysis, you can reduce the lithium levels faster, but the neurotoxicity will take time to resolve, because in chronic toxicity, as I told you, lithium is actually getting exchanged between intravascular compartment and the CNS compartment. So if the intravascular compartment levels are increasing, and if it's more than 2.5 in chronic toxicity, means the CNS is already saturated. CNS is already saturated, that's what it means. And that is why it is not able to move further into the CNS, and the intravascular levels are actually increasing. So in this setting, give a dialysis and remove the lithium. So once you remove the lithium, now the intravascular levels are low, in the sense now the lithium will start spilling from the CNS into the intravascular compartment. Once the CNS levels decrease, once it redistributes back to the intravascular compartment and it's getting eliminated to the renal route or hemodialysis route, your CNS toxicity will decrease over time. So this redistribution back to the intravascular compartment and excretion into the kidneys will take certain amount of weeks, and that you have to be a little bit clear as well. So so you have to admit and you have to wait. So there's no other thing that you have to do. So you can discharge the patient to an extent before by stopping all the lithium, and you can send the patient home. But you have to clearly advise the patient that even after they go home, it might take weeks to get resolved from lithium toxicity. Clear? So lithium is something very important to understand for your exam as well. So especially the toxicology principle, there are multiple questions that have come in the past as far as lithium toxicity is concerned. So if you have any doubts, you can ask. Otherwise, we can wind the session. There is a difference between forced diuresis and forced alkaline diuresis. This is nothing, I told you already. Forced diuresis is different, forced alkaline diuresis is different. Forced alkaline diuresis, you are going to use soda bicarbonate, and this is not indicated in lithium, because this is called as forced alkaline diuresis, because giving bicarbonate will make the urine alkaline, and you are going to maintain the urine pH of more than 7. So this is what we refer to as forced alkaline diuresis. It's used in certain poisonings, but not all. For example, it can be used in rhabdomyolysis to enhance the myoglobin elimination, but not used in all the poisonings. But on the other hand, you can have something called a forced diuresis, which means here the idea is to maintain a high urinary output. High urinary output in the sense when it is more than 1 ml per kilogram per hour. So, or at least more than 60 ml per hour minimum. So it is more than 60 ml per hour, or at least more than 1.5 liters. So this is what we refer to as a forced diuresis, not alkaline diuresis. But to be frank, so the most important definition is the phase, especially when you are dealing about acute injections. This is the cutoff. So you have to maintain urine output at a rate of more than 1 ml per kilogram per hour. You know what is the normal urine output? Normal urine output is 1 ml per kilogram per hour. When you maintain at a rate of more than 1 ml per kilogram per hour, that is a forced diuresis. And that can be achieved using IV fluids itself. A good amount of IV fluids. Some people use Lasix, loop diuretics for the same, but I don't generally give loop diuretics for this purpose. I generally use just a plain normal saline, 0.9% NaCl, and you have to give as much of 0.9% NaCl to maintain the urine output to more than 1 ml per kilogram per hour. But if your center is asking you to do Lasix, then that's fine, but I generally don't prefer Lasix, and even the guidelines don't generally prefer Lasix to achieve that urine output. So because Lasix might result in little bit more dehydration, and then it won't be a good thing to do. And Lasix itself has some nephrotoxic effects, so it's better not to use it. I think CHAM 666 is now knowing about what is the difference between forced alkaline diuresis and forced diuresis. Okay, so if you are okay with it, so then probably we can wind up the session. Okay, so whatever is possible, whatever is needed for lithium toxicity, I have told already. So we will stop the session. Okay, so if you don't have any more doubts. So 30 seconds. Okay, cool. Thank you very much. Okay, bye. Good night. And what are the monitoring? Can anyone tell what are the monitoring that is actually required for this? Is a very practical aspect. So whenever you are prescribing lithium or whenever the patient is taking lithium, so what are the monitoring? So what are the different entities that you have to monitor? For example, every 3 months in the first year, you have to check serum lithium levels. So point number 1, every 3 months in the first year of prescribing lithium, you have to check serum lithium levels, and then you have to check every 6 months. So point number 1. So how to monitor serum lithium and when to take serum lithium levels? Usually after at least 12 hours of the previous dose. At least after 12 hours of the previous dose, you have to take lithium, and every 3 months you have to do serum lithium levels in the first year, and every 6 months from there on. At the same time, every 6 months you have to check for the GFR, that is the serum creatinine bun creatinine ratio. That is totally, you can call it as a GFR. Every 6 months you have to check the GFR. Every 6 months you have to check the thyroid function test, especially in the form of TSH, because lithium causes primary hypothyroidism. And every 6 months once you have to check for the calcium because of the risk of the distal RTA and all these associated problems. You have to check for the calcium every 6 months, and you have to check for the weight every 6 months. So other things that you have to be checked is CBC, complete blood count, and cardiac function if clinically indicated. In case if there are some indications take, you can take if clinically indicated. Suppose if patient is not having toxicity, I mean toxic injections is not there, but when to stop lithium is the question. So if the serum lithium levels are more than 1.5 millimoles per liter, and if lithium toxicity is suspected, you can stop the lithium. It is not an indication to admit the patient, or it is not an indication to take for dialysis. At the same time, it's not an indication to take for any other intervention to consider as acute injection or chronic toxicity. So it's an alarm level when it is more than 1.5, and if the patient is showing some signs of toxicity, then it's better to stop the lithium as soon as possible. So let me write that very clearly, because this is also something very commonly asked. So more than 1.5 millimoles per liter, plus if the patient is having suspected toxicity, it's better to stop lithium. But what is the therapeutic levels? It's maintained at 0.8 to 1.2. These are considered to be the maximum therapeutic limit, even though the limits are variable. Therapeutic level is maintained at only 0.8 to 1.2. But at the same time, certain guidelines are there which are telling like it should be only in the 0.4 to 0.6 range. So that's different. So that is different. So 0.8 to 1.2 is the usual therapeutic levels. And if it is more than 1.5 plus suspected toxicity, you stop. Suppose the patient is having more than 2 plus suspected toxicity. If you are a primary care physician, this is the sign of referral. Suspected toxicity in this setting, you have to refer the patient. Referral is the key here. And obviously, you have to stop the lithium as soon as possible. Chronic more than 2.5, irrespective of the toxicity, is an indication for taking for hemodialysis. So this is how you can classify. So 0.8 to 1.2 is the therapeutic levels, even though remember certain guidelines tell 0.4 to 0.6 is the therapeutic levels. So this is something different depending on the clinical status of the patient as well. But beyond 1.5 stop, more than 2 stop and refer the patient to some tertiary care center. And if it's more than 2.5, it's a definite indication for taking for hemodialysis. And the one more indication for taking for hemodialysis, any evidence of neurotoxicity. So you have to take the patient for hemodialysis in that perspective. Clear? So let us